Okay, good morning, good afternoon. Good afternoon. If you can hear me, clap your hands one time. If you can hear me, clap your hands 2 times. Now everybody say shh. It works for my children's kindergarten class. I'm always surprised that it works here, but it's so effective. A couple of big announcements up front. First off, I'm Dr. Epstein, Eric. An endocrinologist at Montefiore. Welcome to Endocrine class of 2016. I didn't make the cookies. Stand up if you made the cookies. Those are the people you need to thank for making the cookies. I did not make the cookies, and I don't expect there to be cookies here every day. I also didn't provide the Chopin that was being played for you, which was very nice. The way to my heart is Beethoven, but I like Chopin as well. And after my harrowing talk on obesity, I don't know if you've heard from your colleagues, the whole cookie section will probably either be returned or just stay up here with lots of untouched cookies. So, welcome to endocrinology. So this is one of your early pathophysiology courses. Now, pathophysiology is a little bit difficult to get a handle on because you may or may not know how these endocrine systems work correctly, but we will review those from time to time. But we are also going to kind of quickly review how things are supposed to work in order to move on to diseases and pathophysiology, why things are working the way that they shouldn't be working, and how it is we go about doing what it is we try and do to fix them. And that's the crux of the course. It's a little bit of a struggle because I think you've only had renal up to this point. But that's what we're here for, to guide you. Always want you asking questions. Never feel afraid to ask a question. There's no such thing as a bad question. Can you close that behind you? Thanks. Okay, so how is the course laid out? You'll see on eMed, I've basically labeled everything into different folders. That's the order with which we're going to run through the variety of topics. There are some larger topics like hypothalamus, thyroid, adrenal, calcium, and diabetes. They all have multiple lectures associated with them. Most of them, it's usually 2 lectures followed by a small group case conference where you'll go over a series of 4 to 5 cases with a professional endocrinologist and sometimes associated clinical cytologist or pathologist or diabetes educator or nutritionist, and kind of reinforce all of the things that we went over in lecture. There are some lecture topics where you will just get a lecture and we actually don't have a case conference assigned to it. Those are lipoproteins, growth and development, endocrine hypertension, neoplasia, obesity and appetite regulation. And then I'm going to do a review session at the end that we call Endorama. There was a little bit of a change in the schedule. Usually in the middle of diabetes, we do a patient experience where somebody with type 1 diabetes who's on an insulin pump comes to talk to you and you get to ask a lot of questions. We're going to do that again this year, but it comes sort of at the end of the diabetes section, not really in the middle of it. And then we'll go right into Endorama after that, which will be a review session before the final exam. So here are the case conferences for the endocrine course: hypothalamus, thyroid, adrenal, calcium, metabolic bone disease, and diabetes. Obesity actually is under the jurisdiction of the evidence-based medicine course. You are still entirely responsible for everything that we learn about in terms of obesity and appetite regulation, but the small group session is actually dedicated to teasing apart a clinical trial. And that kind of skill set, although important, is not something that I'm going to be asking you to be responsible for. So how do the case conferences work? So like I said, they come usually right on the heels of the lecture for that session. So there'll be like a 2-hour morning lecture. Then there'll be a morning case conference and an afternoon. The only exception is thyroid, where we run just 1 session with an endocrinologist and a cytologist or pathologist, and we provide you lunch. And it ends a little bit earlier. There's a list in eMed of your group assignments, and along with those group assignments, it'll tell you the 2 or 3 students assigned to each individual case conference, and sort of the expectation is that those students would get together, meet in advance, and sort of run through the questions, divvy up the questions, and figure out how they want to run the session. The facilitators for the case conferences are merely there to facilitate. They are not actually there to re-lecture or just basically take over the session and answer questions. We expect this to be very interactive, as are my lectures. Interactive, so if you have a question, by all means just stop and ask. Other lecturers may want you to hold your questions off until the end. But one of the things that you'll hear me say time and time again is the most important thing to me is that you are all going to grow up to be endocrinologists. If you fail me there, that's one thing, okay? The second most important thing to me is that although I know, statistically speaking, maybe one of you will grow up to be an endocrinologist, I'd like you all to be comfortable interpreting endocrinology lab values. And we'll go over a bit of that today, because that's a skill set that you just should keep practicing and practicing and practicing. You will wow your interns and residents when you hit the floors if you're able to interpret things like thyroid tests and adrenal tests, because they're not easy to interpret. It's pretty intuitive once you get used to it, and I'll constantly remind you of some of the hiccups that clinicians face out in the real world. So 1, you all become endocrinologists. 2, you learn how to study and interpret endocrine testing. And 3, and this is actually number 1, is that you don't leave here with any incorrect assumptions. So if you have a question, we would like to know about it. All of the endocrinologists who are in this course are in it because they love to teach, and they're here and they want to share their expertise. You know, we are the nerds that sit in a corner at a party discussing unusual thyroid presentations. That's just how we do things. And so we want to be there and available, but I don't want you walking away thinking, well, this is a dumb question, I won't ask it, then going somewhere and having that scenario pop up in front of you, and you never ask the question and you have the wrong information in your head. So make sure you always ask it. It is what we are here to do. Okay? If you ever find any negative feedback about a question like that, by all means, please let me know. So what are the course resources? So there is, inside each of the folders, is a document called the Learning Objectives. The Learning Objectives is a series of what we expect or what we think are the most important points for each different topic. All right, you'll see a series of anywhere between 6 or maybe even 20 of them, depending on how in-depth the topic is. Other things that you're going to find in those folders are a syllabus chapter, and then the case conferences, the lecture slides, and textbook material that you can read if you choose to read. It is not required. It's recommended, but it's not required. I understand it's not easy for everybody to get a textbook, and I don't expect you all to be endocrinologists, even though I just told you the most important thing is for you to all become endocrinologists. Final exam. So 2 years ago, I took quite a flogging for giving a long, in-depth, clinically based exam. I eased up on it a little bit last year and took a moderate flogging, but it was not as severe as the one from before. The good thing about this course is there's one exam, I never see you again. So by the time I see you, you either have forgotten how the exam was or you've just accepted my humblest apologies. It's usually about 65 to 75 questions. It's a mix of basic science and clinical cases. I try and make the questions to mimic things that you will see on step 1, but it is not an exam that is modeled after step 1. Okay? I'm always available to do review sessions and help you guys with the first aid books and all of those things later on in the year, but the course itself and the exam is not actually laser focused on step 1. So just some tips. Anything you hear multiple times, that's usually pretty important. Continue to look at your learning objectives and your study questions, and absolutely don't miss that session, because I'm going to show you exactly what the questions look like in a very interactive format, and we'll go through as many as we can get through in a given hour that we have. Okay, so that is all sort of the nuts and bolts things regarding the course. Does anybody have any questions before I move on? Okay, so my parents still don't know what an endocrinologist is, and I've only been doing this for, well, a while. What is the endocrine system? The endocrine system, you're taking neuro now, right? So the endocrine system is like a more laid-back, more, don't say this to Dr. Arezzo, thoughtful approach to how you interpret stimuli. All right, there's many different stimuli that come in from the environment, go up to the central nervous system. There's a lot of feedback loops in the central nervous system that usually make their way down to the hypothalamus and anterior pituitary. Anterior pituitary is known sometimes as the master gland. All of that information is then interpreted there, and a series of effector actions are then take place, where there's a series of hormones that get released that go down to endocrine glands in the periphery, our effector target endocrine glands, which then release their hormones, which go out and do what it is that hormones do, and also go back, feedback here to keep the system in check. But it's not an instantaneous system, okay? It's an actual system that takes time. Things have to travel from one place to the other. Some things are faster than others. And we'll kind of walk through how the system itself works. As opposed to the central nervous system with reflexes that are, quick and immediate, this is something where hormone signals go from one part of the body to another, travel over long distances, get processed, signal transduction and things like that are increased or decreased. An effect is then laid out, and then the system gets a check on exactly what happened. It's very elaborate, and I find it fascinating. And we will use sort of the guidelines of what I talked to you about today as the approach to how you figure out what's going on in these clinical cases. Incidentally, by the way, my parents don't understand that I'm an endocrinologist. My daughter won't let me take out the stitches that are in her knee that need to come out on Sunday because she doesn't think, as an endocrinologist, that I know how to take out stitches. Anyway, so a couple different terms for you to understand. Autocrine feedback is feedback for a cell to itself. Okay? The classic example here is the pancreatic islet cell. This is, you can consider this to be a beta cell. This is a receptor for glucose. Here's a receptor for insulin. Glucose is traveling around in the circulation. If the glucose level goes up, that's going to be sensed, okay, basically by the pancreatic islet cell, the beta cell. And insulin is then going to be released. But insulin is also going to feed back on itself to turn off the release of any more insulin. So glucose levels go up, insulin levels rise, because that's what you need in order to dispose of that glucose, and then the insulin levels themselves turn off the production of more insulin. There's a lot of other things that happen, but that's a classic autocrine reaction. Now, there's also paracrine. Paracrine is not to your own self as the cell that sent out the hormone, but to neighboring cells. So the classic example is in the testis. We have the Leydig cells, which respond to luteinizing hormone to make testosterone, and we have the Sertoli cells, which are the sperm-producing cells. Incidentally, reproductive endocrinology is its own separate course. So we'll touch on some of those topics, but much more full to come in that actual course, not here. So here we have testosterone basically traveling out and binding to its nuclear receptor. Testosterone is a steroid hormone. It binds to nuclear receptors. We'll go over that in a couple of minutes. And the testosterone then upregulates transcription and translation to produce sperm. Okay? Now this year I added that graphic. And it took me a little while, and you can see I messed this one up. I must have hit that button that kind of flips it to the other way. But I was pretty proud of it. I couldn't make them, swim. That I couldn't do. But maybe for next year I'll get them to do that. So that's autocrine and that's paracrine, but this is endocrine, okay? So what we have over on this side of the screen is the anterior pituitary. This is a thyrotroph cell. This is the cell that is responsible for making thyroid-stimulating hormone. We're going to go over all the specifics again later, okay? So don't worry about the specific names. This is just general concepts here. So this cell makes thyroid-stimulating hormone, which is the hormone that goes to the thyroid follicular cells and induces them to actually produce thyroid hormone, which we call thyroxine. So how does this system work? Well, if there's a need to make more thyroxine, then the anterior pituitary is going to get that message from the hypothalamus. It is going to release thyroid-stimulating hormone, which will travel from the anterior pituitary and find its way to the thyroid in the anterior part of your neck. TSH binds to its cell surface receptor here and upregulates the signals that allow for the production and release of thyroxine. Thyroxine then goes off and does its thing out in the periphery. But some of that thyroxine is actually going to travel back to the anterior pituitary Okay? And it's going to bind on its cell surface receptor. Actually, sorry, thyroxine binds to a nuclear receptor. It's going to bind to its nuclear receptor and then decrease the release of TSH. So there was a signal in the body that we needed more thyroid hormone called thyroxine. The hypothalamus sensed it, released a hormone, went to the anterior pituitary. That releases a hormone. That hormone goes then down to the thyroid, which produces the thyroid hormone the body needs. And then the system is put back in check by that amount of thyroid hormone or thyroxine. And this is classic negative feedback. And this is basically what we do every day as endocrinologists in trying to figure out where the disease may be coming from. There are a variety of hormones and a variety of different compounds that make up hormones. One day I hope everybody will understand that all chemicals in the body can basically function as hormones. You can have cations. Calcium is a hormone in the sense that calcium is sensed by a receptor in the parathyroid gland. That was very novel, and you'll learn a lot more about that from Dr. Spiegel. Right, forgot to say this. Dr. Spiegel, the Dean Spiegel, he uses the audience response clickers. Nobody else in the course does. Just remember to please bring your audience response clickers, okay? Or I won't be here to teach the course next year. Hormones could be amino acid derivatives. They could be peptides, large and small. They could be glycosylated peptides, and I'll show you that. There are steroid hormones, and there are vitamin derivatives. Vitamin D is not a vitamin, okay, technically speaking. When the sunlight hits your skin, you make it, and so that's not a vitamin. Vitamins are things that your body can't make. The hormones are basically sensed by two types of receptors, cell surface receptors and nuclear receptors. They have their effects, protein synthesis, second messenger pathways, increase, decrease cyclic AMP, and then you get a physiologic response. And this whole system mediates growth, homeostasis, reproduction, energy production, utilization, and storage. Energy production, utilization, and storage, that's all, I mean, that is the issue right now that's going on with the obesity pandemic. And the obesity pandemic will be followed soon after that by the diabetes pandemic. So what classes of hormones are there? Well, there's amino acid derivatives. Remember, anything that's traveling over a long space to another cell to signal it. All right, we're going to teach you that dopamine goes from the hypothalamus down into the anterior pituitary to turn off prolactin production. Catecholamines come from the adrenal medulla. Serotonin can be considered a hormone. There are dipeptides, the two thyroid hormones, T4 and T3. This is T4, this is T3. They're both iodinated dipeptides. There are larger peptides. There are glycoproteins. You probably know this by now. They all have the same alpha subunit, but a distinct beta subunit. There's very interesting interactions since HCG and TSH are both very similar to each other. When HCG levels rise, TSH levels can fall because this can actually bind the TSH receptor. And you'll learn about that in reproductive endocrinology, but it's a form of perfectly normal physiologic changes in the way that the thyroid tests look in early pregnancy. And then there's steroid-based hormones. So testosterone, cortisol, vitamin D. Vitamin D is not a steroid, okay? But it does fall under more of that steroid ring class of hormones. So these are the classes of hormones. Remember, there's two kinds of receptors. There's a couple of exceptions to sort of classical rules that I will tell you about. These are the cell surface receptors. They usually bind hormones that are water soluble. Because they're water soluble, they don't need a binding protein to travel in the circulation. If they were water insoluble, they'd need a binding protein to travel in the circulation. Exceptions to this, IGF-1 travels bound to the IGF-1 binding protein, or IGF-BP. The hormones themselves don't diffuse across the cell membrane. They actually bind their cell surface receptor and mediate their action through that way. Now, on the flip side, there are hormones that use nuclear receptors, and these are more the steroid or sterol-like hormones. They use nuclear receptors, so they diffuse basically right across the cell membrane, find their nuclear receptor, and then initiate their action plan, so to speak, down in the nucleus. They are water insoluble for the most part and travel bound to binding proteins. So for testosterone and estradiol, we have sex hormone binding globulin. For cortisol, we have cortisol binding globulin. For vitamin D, we have vitamin D binding protein. Endocrinologists are not the savviest of name givers. Although we do have some names of diseases that make things really confusing. But we'll get to that. Now, thyroid hormone's the exception. It's a dipeptide, but it binds or travels in the circulation bound, exquisitely bound, actually. It's thyroxine binding globulin is the main hormone that binds thyroid hormone. But it's a bit of an exception to the peptide rule, not only because it binds a binding globulin, but because it has a nuclear receptor and not a cell surface receptor. Okay, so if you use a nuclear receptor, generally speaking, it requires binding proteins that are water insoluble and they diffuse across cell membranes. So before I go into an in-depth discussion of a hormone we won't talk a lot about after today, does anybody have any questions? Okay. So we're going to pick one hormone, or I will pick the hormone. You can pick the hormone when you guys are endocrinologists and up here, but for today, I will pick it. And we're going to pick somatostatin. So this is a hormone that sort of is a great example of the differential properties that a single hormone can have depending on where it's made, how it's made, what receptor is binding it, what the action plan of that receptor is going to be in that specific cell, and then how we use it, either through pharmacology or through radiology, to take advantage of the properties of that hormone and allow it to work sort of for us in a way that can either decrease the disease burden on somebody or actually show us what the disease burden on somebody may be. So somatostatin comes, generally speaking, in two different forms. Okay? It's actually found and synthesized in lots of cells. Hypothalamus, the pancreatic delta cell, which you probably learned about already. Gastrointestinal epithelial cells, myenteric plexus, a bunch of CNS things. In the CNS and the hypothalamus, it's usually this form, somatostatin 14. Okay? In the gastrointestinal tract, it's usually this form here, somatostatin 28. And you can see here that there's obviously differential splicing that happens after the mRNA is formed, before translation occurs. And these are the various forms that we see. This is the one that works in the central nervous system to decrease growth hormone. And this is the one that works in the gastrointestinal tract to kind of slow the system down, decrease gallbladder contractility, and decrease pancreatic enzyme release. So already, and this will come up for a couple of our disease states, differential splicing of what we basically consider to be the same hormone can mediate different effects, depending on where it's made and how it's going to respond. So hormones don't affect cells that don't have receptors for them. Okay, we will learn in the bone that in the bone, osteoclasts don't have parathyroid hormone receptors on them. Osteoblasts do. And that parathyroid hormone will bind to the receptor on osteoblast to mediate an activity that the osteoclast carries out. But the osteoclast can't respond to PTH. Okay? So hormones can only respond to where there is a receptor. And there are 5 receptors for somatostatin. They are located in any of these various areas. And so you can imagine that somatostatin plays a role anywhere where there's going to be receptors for them. We'll focus here on type 2 and type 5. So type 2 is very commonly found in anterior pituitary somatotrophs and alpha islets. The alpha cells in the islets are basically where glucagon is made. Type 5 is also found a little bit there, okay, depending on what cells you're looking at, and in the beta cells. That's where insulin is produced. Okay? So what is the actual activity of somatostatin? Well, classically speaking, this is somatostatin up here. This is an old term. I don't know exactly what it stands for. It has some effect on TSH, but the main effect of somatostatin is to turn off growth hormone production up in the hypothalamus, and the anterior pituitary. Down here in the pancreatic cells, there's a very elaborate feedback system where somatostatin is released and it turns off glucagon production and it turns off insulin production. It's one of those other checks I mentioned when I said that high blood sugar values increase the release of insulin, and then insulin turns itself off, where there's other things that turn off insulin as well. So there's some crosstalk. This is the form of somatostatin basically in the gastrointestinal tract that does other things that you learn about. But gallbladder contractility and pancreatic secretions, those are exocrine functions. And I am not an exocrinologist. I am an endocrinologist. Endo means ductless gland. It's what's part of the derivation is ductless. So we deal with ductless glands. If there's a duct, salivary gland, sweat gland, I'm not your guy. But if there's no duct, thyroid, adrenal, pituitary, then I can help. How do we use somatostatin? Well, remember I said that it can have activity wherever you find a receptor for it, right? So the SSTR type 2 receptor is really what bathes the somatotrophs in the anterior pituitary. And from the hypothalamus, somatostatin comes down and turns off growth hormone production. Okay? Now, let's stop typing for a second and tell me what's wrong with this gentleman on the left panel of D. Throw a hand up. Yeah. His tongue is large. Is that what you said? Talk medical speak to me. It is hypertrophic. Good. So the word for that is macroglossia. Good. Excellent. His tongue is enlarged. Fantastic. What else? What? Yeah, go ahead. You can't be wrong here.
I'm wondering what was on his neck.
What is on his neck? What is this? Say it. I heard it. A trach tube. So what happens here? He can't breathe because his tongue is too large. When he lies down at night, the tongue actually blocks his airway. Obstructive sleep apnea. See, you guys know all this medicine already. This is a hole in his trachea so that you could put a breathing machine on this so when he lies down at night, he doesn't asphyxiate. Excellent. What else? One more thing. Well, a couple more things, but... Yes, he has this tube coming over his head down here. What is that doing? Yeah. Why do you need to feed him that way? Same plumbing, right? I mean, it's the same hole. Goes down a different hole after you swallow, but it's basically the same oropharynx. He can't use it. Now, also, and this is subtle, but if we talked to him or looked at pictures from 20 years ago, we would probably notice that his ears are a little bit larger than they were before. His nose, the cartilage in his nose, his jaw is going to be prominent. He's going to have swelling and arthritis in his hands and knees. He probably suffers from congestive heart failure because of an overgrown heart that doesn't pump so well anymore. Do you know what he has? Well, he does have a tumor in the pituitary. Very good. That's good. But what's it called? What's it making? Growth hormone. He has acromegaly. He has the disorder that's associated with, please pardon me if I'm dating myself here, Andre the Giant, the wrestler. Okay? So he has too much production of growth hormone from the somatotrophs in the anterior pituitary. And it is causing life-threatening problems. If he didn't have these, he'd be dead. Okay? It's not usually this drastic. Now, it would be fantastic if we had some way to turn off the growth hormone production from that tumor. Well, I'll tell you, he already had surgery, and there's still residual tumor there. And they radiated his pituitary, and there's still residual tumor there. So what else do you think we could possibly do? Well, this is what somatostatin looks like, and this is the hormone that turns off growth hormone production. This is made by a pharmaceutical company, and it's called octreotide. And what do you know? It looks an awful lot like somatostatin. And it happens to have really high affinity for SSTR2. And so we give this as an injection, and as you can see here, growth hormone levels fall within a few months. IGF-1, which is the actual effector arm of growth hormone, falls within a few months. Growth hormone secretion at a year is almost down to normal. And lo and behold, the tracheostomy is sewed up and reversed. He doesn't need a feeding tube anymore, and his macroglossia has been markedly reduced. This drug is called Octreotide, we use it for other things too. But this is sort of the main medical therapy we have for this condition called acromegaly. Yeah?
Why did his macroglossia reduce?
So why did his macroglossia reduce? So over time, the hypertrophy and edema and swelling that's there will come down. It does take a long time. It's not happening overnight. Good question. Yes?
How long will he be stable on a dose like that? Is it because this is endocrinology, right? So everything is going to try to move back to its...
Yeah, so, well, basically, this is telling you a cure rate. So about a third of patients are not going to be cured even with the drug. The question was, how long is he going to be stable on this drug? Many people respond, more than 2/3, and they do great on this. If they don't respond to this, we have other fancier versions of the same thing.
Okay, so
We'll get to that. We'll get to that. We'll get to that. Okay, so one way to use somatostatin analog. Well, here's another way that we can use somatostatin analog. Okay, I can't go over what this person is suffering from because I'm going to give this lecture and I'm going to want you to go over all of that stuff with me, just like we did right now. But I will tell you this person is suffering from something called Cushing's disease. Cushing's disease is a tumor in the anterior pituitary that is not secreting growth hormone, it's secreting ACTH. And that is going down to this person's adrenal glands and making the adrenal glands secrete a very high level of cortisol. And that's causing all these problems, which we're going to get into. Now, it turns out, and this is from the New England Journal from last year, it turns out that when these anterior pituitary tumors start to secrete too much ACTH, they also begin to upregulate expression of somatostatin receptor 5. So, it was thought, and it took a long time to do this, but if we had a drug, now octreotide doesn't really bind 5, so that drug doesn't work so well in this disease. But if we had another drug that bound SSTR5, well, then we may be able to decrease the ACTH production, and lo and behold, that should help with the cortisol production. And that's what we have. It's a medicine called pasireotide, and it's relatively new. It will not work on problems that cause Cushing's in the adrenals. It will only work in problems where the adenoma in the pituitary is making too much ACTH, and it will only work if that tumor is increased its expression of SSTR5. Now, you can see here in this graph that this is a normal hash line for what you should make of cortisol in a day. And nobody is normalized. Well, we're looking at a mean here. Some people were normalized, but most everybody's not normalized. But the production of cortisol is markedly reduced. And that may make people quite symptom-free for what hopefully will be a pretty long time. So it's not a curative drug, but it certainly helps. But you see here, I left this one here. SSTR5, anything that binds it and activates it, is going to turn off insulin production. Because I just told you somatostatin in the pancreatic islet cells is there to decrease insulin production from beta cells. And beta cells have a preferential SSTR5 expression. So what happens to these patients when we put them on this drug? Yep.
Become diabetic?
They become diabetic, absolutely. We have to tolerate that. Cortisol alone could make them diabetic. We tolerate that and we give them medication for it, but it is seen in a very high percentage of patients, unfortunately. Now, SSTR2 is not expressed there. And so we can give octreotide, and there is not really much of an effect on glucose homeostasis, the way that there is here. And so I'm showing you this because, remember, where the hormone receptor is going to tell you a little bit about what its action plan is and what its effect is going to be. Any questions on that? Yeah?
Just want to confirm. So the reason that makes the guy diabetic is the guy takes the medication and it's blocking the receptor and so that's going to stop the production of somatostatin?
No. So SSTR5 is a somatostatin receptor in the pancreatic islet. It's going to decrease the production of insulin. And if you don't make insulin, you're going to have trouble disposing of glucose. And you're going to have trouble stopping your liver from making glucose, but that's for another day. So what else can we do with this? Well, if we know where receptors may be, if we know there are certain cancers out there that preferentially express somatostatin receptors, we can take somatostatin and we can throw radio-labeled material on it, send it in to the body, and force it to show us where cancer may be. And that's what's happened with this unfortunate patient who is suffering from a neuroendocrine tumor. Does anybody know what this is? This anterior, looking like this, posterior, not my best side, but looking like that. Anybody know what that may be? It's not the gallbladder. What? Yeah, that's the pancreas. So the pancreas is home to glucagon-producing cells, insulin-producing cells, somatostatin-producing cells, and a lot of neuroendocrine tumors live there and are sort of bred there. What is this here? That's the liver. So what do you think that means if I told you that this person has a neuroendocrine cancer? He has metastasis. That cancer has spread. Without this, I mean, we could do other types of imaging, but this is very specific. And this completely changes the treatment plan for this patient. Now, it turns out that we also have radiolabeled material which could destroy cells. So we could radiolabel the octreotide or somatostatin analog, send it in, and actually use it as a way of directly targeting tissue to be killed in the setting of cancer. So that's a little bit about how the hormones work. That's an introduction to hormones, classes of hormones, receptors. I want to take you back a second because this is where the rest of the talk, again, this is not specific. This is general things, but we're going to hit something that's really important. And I will tip you off as to when that's coming. It's coming. Remember I said that basically the endocrine system is a way of sort of monitoring the environment, internal and external. And that we have target organs, okay, that make hormones that go out and do their effects in peripheral tissue, but then feed back on both the hypothalamus and the pituitary. Well, if you have a problem here in the hypothalamus or pituitary, we refer to that as central problem. And if you have a problem out here, we refer to that as primary. So when we're talking about a hormone deficiency, it's really in the context of deficiencies, hypothalamic and pituitary problems are central or secondary problems. It used to be that this was labeled tertiary and this was labeled secondary. We don't measure these hormones. They're not seen in the peripheral circulation at concentrations that mean anything. So we've lumped them together. Secondary hormone deficiencies, primary hormone deficiencies. Now there are some hormone deficiencies where a secondary or a primary problem looks exactly the same when you see the person in the office. So use your clinical skills and tell me what do you see here? What's she suffering? Don't tell me the disease, but describe her to me. She has exophthalmos. She does not have exophthalmos, actually. Exophthalmos is a term for inflammation and edema behind the eye that pushes the eye forward and induces proptosis. What you're looking at here is something else. We'll get into that in a couple of slides. Yeah? Does she have an issue with her thyroid hormone? Yes. But I want you to describe her to me. Keep going.
Is that orbital edema?
Yeah, so this is called periorbital edema, a classic sign, not specific, of really severe underactive thyroid or thyroid deficiency. Yeah? Hypothyroidism, right. But okay. So you're all good, excellent diagnosticians, but I need you to describe her to me. So describe her to me. Tell me what she looks like. Right? If you come to talk to me about somebody who you've seen in a room, I'm not going to see them. I want to know what they look like. Yeah? No, I think that's just elderly hands, more or less. But there's a lot of swelling here, okay? And you see all this swelling down here? Good. Does she look happy? Severe hypothyroidism is associated with a type of sort of masked faces is kind of what we call it. What's she doing? She's sitting down. There's a proximal myopathy associated with hypothyroidism that makes it really hard for people to stand up. And we'll go over that. It's not specific. Maybe a little bit. But it's really about the swelling around the eyes, the masked expression. These are not the same person. and a lot of swelling in the extremities. Now, these are all the things she's going to tell you that she's suffering from. So you start to talk about this and you describe this, okay? But I immediately look at this. So where you see this and start describing it to me, I would start to think about this. Because with this disease and all hormone deficiencies, I want to know, where is the problem? Is it up in the central zone or is it down in the periphery? Okay, primary versus secondary. So how do I make that distinction? Well, a primary hormone deficit is an end organ deficit. In this case, if we're talking about the thyroid, it's the thyroid gland. If you surgically remove somebody's thyroid, the first response is that the peripheral hormones are going to fall. Okay? So T3 and T4 fall. And because of negative feedback, the hypothalamus is going to figure that out. And it is going to increase TRH. We will go over the specifics again. TRH is going to rise. It is going to bathe the anterior pituitary and increase the production of TSH. Okay? So in a primary deficit, we have a decreased concentration of the end organ hormone and a rise of the central hormones. That's the appropriate response that we expect to see. So peripheral hormone level is low. Stimulating hormone is high. This is a primary deficit. Okay? How does that differ from a secondary problem? Well, in a secondary problem, you have to think hypothalamus and pituitary, and the deficit's up here. Let's say somebody had their pituitary operated on and then got radiated. Okay? You have destruction of the hypothalamus, destruction of the pituitary. As opposed to the last case, the first thing that happens is TRH and TSH fall. Remember, we don't measure hypothalamic hormones. But the drop in TSH is going to atrophy the thyroid gland. There's no stimulating hormone. There's no production of peripheral hormones. So in a secondary hormone deficit, you get low T4 with low TSH. Okay? You must be comfortable with that. We'll go over it again, but you have to be comfortable with this concept of how to interpret the thyroid test, because they will tell you where the deficit actually is. Now, it turns out that, come on, there we go. It turns out that, I don't know why that came so slowly, but it is so important. I'm glad it did come slowly. You must always think about something called the inappropriately normal situation. I want you to think about this again. You'll see it in your small group case conferences. You'll read about it in the syllabi. This person who has the central deficit can actually secrete a normal amount of TSH. Only the TSH is not normal. It's processed incorrectly. It's not glycosylated. It can't bind the thyroid stimulating hormone receptor on the thyroid gland, so it doesn't work. But it has enough epitopes that if we tried to measure it in a lab assay, we'd pick it up. Okay? But this person would have a really low T4 and T3. So if you see a low free T4, or if you see a low T4 or any peripheral end organ hormone, and you go back and say to yourself, why is this low? What is the response of the pituitary? The response of the pituitary should be to increase the stimulating hormone. And if it is not, even if you find it normal, that's not normal. It shouldn't be that way. The response is to drive the production of TSH up. And we just saw somebody in the hospital with severe hypothyroidism because the physicians were only measuring TSH and it always came back normal. And when someone finally measured this, it came back as completely undetectable. So it is really, really important. Primary care doctors will use this test as a screening test. But you all, even when you go into primary care, which is a great field and I love it, will do this with this. You always need to know what's happening with the end organ and the central hormones. Okay? Okay, yes. I'm getting the nods that I've beaten it to death, so I will move on. Okay. Other types of hormone deficiencies. It's the same fundamental concept. Let's say that someone came into your office and they were suffering from systemic tuberculosis, not very common here in the United States anymore. Tuberculosis has an affinity for the adrenal cortex. Goes in and basically wipes out with granulomatous infiltrates the entirety of the adrenal cortical production. Well, you're going to see a fall in cortisol, and the appropriate response to that is that the hypothalamus is going to drive up CRH, and the anterior pituitary is going to produce ACTH. And this is what this gentleman suffered from, who, since you all see the slides ahead of time and I can't hold back anything anymore, is actually former President John Kennedy. He suffered from what's called Addison's disease. In his case, it wasn't tuberculosis, it was actually autoimmune adrenalitis. So his body's immune system looked at his adrenal cortex as if it was a bacteria or a virus and destroyed it. Okay, now interestingly though, unlike the thyroid case, people who have primary versus secondary adrenal insufficiency do present phenotypically a bit different. And we'll go over that in the adrenal cortex lecture. But there are ways that we can look at some physical features and blood tests to get a sense of whether or not that deficit is coming primary or central. Now, there's not just diseases of hormone deficiency. There are diseases of hormone excess. As I talked about before with Cushing's, there's a variety of causes of Cushing's. The syndrome is what we call any excess cortisol. Okay? I showed you a case of Cushing's disease. This is a little bit different. This is a tumor growing in the adrenal, what we call an adrenal adenoma. That itself secretes a lot of cortisol, and that cortisol goes back and feeds on the anterior pituitary to drive down ACTH. So we've named this very nicely, actually, or I didn't name it, but it got named, ACTH-independent Cushing syndrome. Why ACTH independent? Well, ACTH would be undetectable if you measured it here. Why is it undetectable? Because the lesion is actually in the adrenal cortex. The adrenal cortex is making cortisol. It could care less what the ACTH level is. And it endogenously drives down the ACTH level by being at such high concentrations. So that's what we mean when we say ACTH independent. The pituitary form is different because that's ACTH dependent Cushing's. And again, we will go into that. Now, they look exactly the same. When someone comes into your office, and I think I had a case of this that I started evaluating on a patient yesterday, when someone comes into your office, they have all of these features. Not all of them, but they have most of the features. But you cannot tell just by looking at them or taking a history where that lesion is. You have to do a variety of stimulating and suppressing tests, mostly suppression testing. And we'll go over that again in the adrenal cortex lecture. So we've talked about hormone deficiencies, we've talked about hormone excess. There's also something that's kind of labeled mimic hormones. Now, where's my colleague with the exophthalmos? So this is exophthalmos. This is periorbital, behind the eye, actually, sort of inflammation in the extraocular muscles. Not periorbital, I misspoke. It's extraocular muscle inflammation and swelling. There's not a lot of space back there. And so all that inflammation and swelling pushes the eyes forward, and patients have this phenotype. Now, this is actually caused by the body's immune system making antibodies that mimic TSH. They mimic the thyroid-stimulating hormone. They look just like it. They bind to the thyroid-stimulating hormone receptor, and they are named thyroid-stimulating immunoglobulins. They are the most common cause of an overactive thyroid, and the condition itself is called Graves' disease, named after Dr. Robert Graves. Okay? The exophthalmos is 100% specific for this disease because it's these antibodies that are binding some molecular mimic on the muscles that make it look like the TSH receptor, inducing that kind of inflammation. All other forms of an overactive thyroid will not have this. They may have some eye findings, but not this. So when you see this, because it's only something that's caused by the thyroid-stimulating immunoglobulin, you don't need any other test to make your diagnosis. You know the patient has Graves' disease. Yeah?
When does that usually present?
Well, it's rarer now than it used to be, but it's not uncommon. And it can present at any time. Anybody notice anything else about her? So I have a theory, actually, that we all point to our neck when we talk about the thyroid because we're used to oral descriptive stories. And I'm wondering if over time, like the generation that doesn't, do any oral stories at all, yeah, maybe that's you guys, but maybe they do all the click-clacking and the whatever you do that stuff with, won't necessarily point to their neck anymore. But if you notice in rounds, anybody that talks about the thyroid, if you were just watching rounds, once you start to see this, I guarantee you they're talking about the thyroid. But yes, she has a goiter. What's a goiter? A goiter is any enlargement of the thyroid gland, okay? It could come from an underactive thyroid, a normally functioning thyroid, or an overactive thyroid. Can you guys see this? That little nubbin right there? That's called the pyramidal lobe, okay? These thyroid-stimulating immunoglobulins go into the thyroid, bind the TSH receptor, induce hypertrophy and excess production of the thyroid gland, and this causes a diffuse symmetric enlargement. Looks like a butterfly, with a little bit of a pyramidal lobe here, which is not normally seen. But when the pyramidal lobe gets quite large and detectable, like it is in her, it's sort of one of the signs of Graves' disease. It's not really specific for Graves' disease, but because of the diffuse enlargement, it is something that's important. Now, I mentioned before that we don't name things very well. So here you see something that they've labeled pretibial myxedema. Well, what that is that these thyroid-stimulating immunoglobulins are finding something in the connective tissue of the skin in front of the tibia, in the legs, and it causes a Graves' dermopathy. It is also 100% specific for Graves' disease. But myxedema is the word that we use for severe, life-threatening hypothyroidism. But you see pretibial myxedema only in the setting of hyperthyroidism. Okay? Confusing. I wish I could change it. We like to call this now Graves' dermopathy, but I don't think that it's really hit all the textbooks yet. So be forewarned, that has nothing to do with the myxedema the way we usually talk about myxedema. Now, this is Senior Bush and Mrs. Bush and their dog. When they were in the White House, they all developed overactive thyroids. Okay, this is public knowledge. I wasn't their doctor. I was like 10. Because they all developed, including the dog, an overactive thyroid, they spent millions of dollars trying to figure out who poisoned the water supply that was going into the White House. This is an antibody-mediated disease. You cannot induce it on somebody by giving them iodine or lithium or any of the other things that they were looking for. If they had just spoke to an endocrinologist, we could have sort of saved us all a lot of money, but you know, whatever. We'll all pay for it in the end, but it doesn't matter. Anyway, so those are abnormal hormones. So we've talked about deficiencies, hormone excess, hormone mimics. There's also something called resistance to hormones. Okay, leptin is a hormone that is secreted proportionally to the amount of fat mass that you have. That leptin basically goes up to your central nervous system and turns off your desire to eat and increases your metabolism. Fat levels go up, the brain senses it, you get out there and you move and you stop eating. Okay? One of these mice is resistant to the leptin signal. I'm not going to answer because I know you're intuitive enough to put it together. There are hormone resistance problems. They are almost all acquired. Okay, they're usually picked up much earlier in life, so it's really in pediatrics where we start to see them. Be aware of them. They're not very common, but they're very fascinating when we find them. There's also metabolism and transport of hormone problems. So I mentioned thyroxine, T4, the main thyroid hormone, is bound to a binding globulin. It's called thyroxine-binding globulin, and it binds the vast majority of that thyroxine. Okay, so much so that like very little amount of T4 is free in the circulation, but it's the free amount of thyroid hormone that we care about. Some people are born with a variant of albumin. It's called familial dysalbuminic hyperthyroxinemia, where if you measure the total level of hormone, the albumin binding for the hormone goes up, and the total level of T4 goes up with it. But the TSH stays normal, and the free T4 stays normal. It's an interesting disease, but it's really not a relevant one anymore. It used to be something that people would look at and have to figure out when T4 was only measured as total hormone. Because the only effect that this disease has is to raise the total levels, because more of the thyroid hormone that's secreted gets bound up. But then the free amount that's in the serum is basically what's regulated. So the hypothalamus and the anterior pituitary kick up a little bit of TSH and re-equilibrate with the free T4 level. The same thing happens actually in pregnancy. In the early part of pregnancy, as estrogen levels rise, there's an increase in TBG. If you measure total thyroxine levels, you will see very high levels in pregnant women. If you don't measure free thyroxine levels, you will be fooled into thinking they may have a problem. Okay? It merely has to do with metabolism and transport of the proteins. And then there's, you know, so like the holidays are coming up. Halloween, Thanksgiving, family, well, maybe Halloween's not a family time for everybody, but you're going to be asked now, okay, because this is where the real doctoring comes in, okay, second year, right? I mean, you've been waiting your whole lives for this, I think. You're going to be asked at the dinner table, first off, to look at rashes. Don't look at rashes. Don't go down that road. But you're also going to be asked a lot about your opinion of things that people hear about on the radio. Well, it turns out that endocrinology is all over the radio. Anybody know what that is? Yeah, that's Barry Bonds earlier in his career. Almost unrecognizable compared to his present-day stature. Roger Clemens, Andy Pettit, growth hormone abuser, and apparently acquitted of all charges, but what are you going to do? I'm a Yankees fan, by the way, okay? I was pretty displeased when I found out this, but then I got really excited when these two guys flunked their drug tests, okay? Because they also were abusing androgens, basically. They were abusing testosterone variants. In fact, Manny Ramirez was picked up by having HCG, the hormone that goes up in pregnancy, in his blood because, remember, I said that HCG can sometimes mimic the other glycoproteins. Well, it can mimic LH. LH induces testosterone production. So if you give yourself a lot of HCG, you may be able to upregulate endogenous testosterone production. So this made me happy. And then this guy made me angry again. Somebody apparently from the United States was capable of like riding a bicycle all over France 7 years in a row or something like that. He won it 7 years in a row. It never had been done. And nothing like that had ever been done. And obviously you all know that he was basically using hormones, drive up his... He was using erythropoietin was one of them, also androgen variants. Erythropoietin is a hormone that comes from the kidneys to go to the bone marrow to increase your red blood cells so that you can have more oxygen transport. So he was abusing that. Mr. Armstrong got debunked. This doctor is not related to me in any way. I'm not promoting his book in any way. That is my disclosure. But there's a big thing about growth hormone in milk. You don't really see it anymore because Walmart decided they weren't going to sell any milk that had hormones in it, and Walmart basically drives the entire industry for milk. It literally overnight, growth hormone given to cows almost disappeared. So it's not really an issue anymore. But a lot of these things you're going to learn about here. We're not really going to talk about these guys, but you will learn about in this course. You'll understand the concepts of what they were trying to do, how they were trying to do what it is that they did, why it might be a problem if there's bovine growth hormone actually in your milk, or why it may not be a problem. So I think I'm going to stop there. I think we have more cookies here. Maybe the pianist will come down and do a little bit more for you. And I will see you all again on Tuesday.